So I know that this material was covered in our last lecture video, but I wanted to take a second to go over this once more with a new picture that I've added to the PowerPoint slides. Capillary exchange was discussed in our last lecture recording as the processes by which substances get from one side of the capillaries to the other. Simple diffusion and transcytosis were fairly straightforward, but it was bulk flow that was a little bit more of an intricate topic. So I did go ahead and add a little picture in here that you can all see from your textbook to hopefully help demonstrate bulk flow a little bit better. So I'm just going to take another quick second to go over the concepts of filtration and reabsorption, which together make up what we know as bulk flow. So filtration and reabsorption both refer to pressure-driven movement. This is movement along a gradient from an area of high pressure to an area of low pressure. Really, the only difference between filtration and reabsorption is the direction in which substances are going across the membrane. Filtration is always going to be from the inside of the capillary lumen towards the outside of the capillary. That would be in the interstitial fluid. So the direction of movement of substances out of the capillaries refers to filtration. Reabsorption, on the other hand, is just the exact opposite direction of pressure-driven movement. When substances go from the interstitial fluid back into the capillary's lumen, that's going to be referring to reabsorption. So these two terms only differ in their definitions by the direction that fluid is going to be moving. Now, I also discussed that there are two types of pressure, namely hydrostatic pressure and osmotic pressure. Hydrostatic pressure is a pressure that manifests sort of as a pushing force. Hydrostatic pressure forces substances down their concentration gradients based on the overall pressure inside of a particular chamber. The chamber is referring to either inside of the blood vessels or the space that the interstitial fluid is contained within. Each of those fluids, both blood and interstitial fluid, will produce a hydrostatic pressure. And there's also osmotic pressure. Osmotic pressure is formed by large proteins in solution that are bouncing against the walls of the chamber that they are contained within. That exerts a pressure on the walls and ends up acting like a pulling force, pulling substances into a chamber. And any substance that has any type of large solutes in it is going to have an osmotic pressure as well. So blood naturally has plasma proteins, and there are also some proteins in the interstitial fluid also. So both the interstitial fluid and the blood will both have their own hydrostatic pressures and their own osmotic pressures. The osmotic pressure of the blood functions to pull substances into the blood, and the hydrostatic pressure of the blood functions to push substances out of the blood. And the exact same pressures work exactly the same way with the interstitial fluid. The interstitial fluid's hydrostatic pressure will force substances out of its chamber and into other chambers, such as the blood capillaries, and the interstitial fluid's osmotic pressure will pull substances out of the blood. So it is the direction of these different pressures and which way their gradients are set up that will determine which of these pressures contribute to filtration and reabsorption. Specifically, the hydrostatic pressure of the blood, which acts as a pushing force out of the blood, is going to be in favor of filtration, as this hydrostatic pressure is pushing solutes out into the interstitial fluid. But at the same time, the osmotic pressure of the interstitial fluid is also going to aid in the direction of this pressure gradient. Osmotic pressure is a pulling force. So both the pulling force of the interstitial fluid and the pushing force of the substances in the blood are going to work in the same direction, and therefore both of them contribute to filtration. Reabsorption, on the other hand, just uses the other pressures that are going to direct movement of substances in the other direction. The blood is going to have its own osmotic pressure, and that's going to pull substances into the blood, while the interstitial fluid's hydrostatic pressure will be pushing substances from the interstitial fluid into the blood as well. So both of these pressures act to either push or pull substances back into the bloodstream, and that's why we call this reabsorption. Now that's quite a long-winded explanation, so that's why I wanted to go ahead and throw in this slide so that we can see these various pressures acting in the directions that they do. As blood flows through the capillaries, it's experiencing different pressures as it goes from the arterial tree all the way out to our venous drainage. There is a key up here that will hopefully help to keep you in order about the different types of pressures that we have and which directions they will facilitate movement. So BHP stands for the blood's hydrostatic pressure. It's going to force substances out into the interstitial fluid. Remember, hydrostatic pressure is a pushing force. So that's going to take smaller substances in the blood and force them out into the interstitial fluid. Now, remember at the same time, the blood is also going to have its own osmotic pressure. This BCOP stands for blood colloid osmotic pressure. And for simplicity's sake, you can just refer to that as the osmotic pressure of blood. That produces a pulling force. The plasma proteins inside of the bloodstream are going to be bouncing along the walls, and that is trying to expand the container and pull substances in. So that osmotic pressure will be in the opposite direction as this hydrostatic pressure. So the hydrostatic pressure and the osmotic pressure of the same substance will actually work against one another. You'll also see that we have the interstitial fluid osmotic pressure and the interstitial fluid's hydrostatic pressure. These forces are the same types of forces that blood had, but we have a different fluid on this side of our cell membrane. So this will also produce a hydrostatic pushing force of substances to go into our bloodstream, and there will also be some osmotic pressure that's going to act to pull substances out of the bloodstream. So you can see that the hydrostatic pressure of the blood and the osmotic pressure of the interstitial fluid have their arrows pointing in the exact same direction. That's going to indicate that both of those pressures work together to facilitate what we know as filtration. And you can come down here to actually see that there's a little equation, net filtration pressure. You can see that the direction of flow, filtration versus reabsorption, are going to be fighting each other. Both of these processes are going to have their pressure gradients in different directions. So naturally, they're going against one another. And it is the hydrostatic pressure of the blood and the osmotic pressure of the interstitial fluid that will both facilitate filtration. Now, on the venous end here, we will see that the blood's osmotic pressure and the interstitial fluid's hydrostatic pressure are both going to point their arrows towards the inside of the capillary. And we take both of those variables and we're going to add up their sum. Once we have calculated the sum of the pressures that are going to be facilitating filtration and also calculated the sum of the pressures that are promoting reabsorption, we will take the sum of all the pressures that promote filtration and all the pressures that promote reabsorption, and we will combine them to see which pressure is overall going to be much stronger. This refers to the net filtration pressure. This is the direction of bulk flow in the cardiovascular system at any given point along the cardiovascular tree. So we'll do a little example we can see down here. You can see that the hydrostatic pressure of blood is about 35 millimeters of mercury, and the osmotic pressure of the interstitial fluid is just 1 millimeter of mercury. So we're simply going to take those two numbers and add them up to give us the amount of pressure that is pushing in the direction of filtration. And we'll do the exact same thing with the other pressures that are promoting reabsorption. You can see that the osmotic pressure of blood is about 26 millimeters of mercury, and the interstitial fluid's hydrostatic pressure is about 0. So we're therefore going to take 35 plus 1 and subtract 26 plus 0 from it. And when we do this math, we end up with 10 millimeters of mercury in the direction of filtration. So what that tells us is that while blood is in the arterial tree, substances will be filtering out into the interstitial fluid. But as we move over here to the venous end, you can see that the pressures are drastically going to change. The blood's hydrostatic pressure is much, much less than what it was in the arterial tree. Fortunately, for simplicity's sake, all of the other pressures actually remain the same. But when we change the variable here for filtration, you can see that we no longer have 35 millimeters of mercury, we just have 16 millimeters of mercury in the direction of filtration for the hydrostatic pressure of blood. So when we plug that in, you can actually see that we end up with a negative number, which indicates that there's actually a reabsorption of fluid in the venous end of our cardiovascular tree. This is primarily caused by the difference in the hydrostatic pressure of blood between the arterial end and the venous end. So our NFP is our net filtration pressure, and that's going to tell us what direction substances are going to be going in depending on what the pressures are in that particular segment of the cardiovascular system. So I wanted to make sure that you all had an explanation with this picture. You can find this picture in your textbook on page 748. We will stick to this topic of blood pressure as we go throughout pretty much the rest of our presentation here on the blood vessels. Blood pressure, as we've talked about so far, is a very, very necessary and important factor of our overall bodily health. As you have been able to see by now, there are many different pressures that are changing inside of the cardiovascular system. We have a pressure inside of the left ventricle that's going to determine whether blood is ejected or not. We have pressures inside of our vessels that are going to decrease as we go from the arterial side over to the venous end. And despite being rather trivial, you'll also see that there are pressures to the interstitial fluid also. So we're going to take a little while to go over blood pressure specifically, what is known as our systemic blood pressure. There's lots of different pressures, but our systemic blood pressure is the one that we are most medically concerned with. The systemic blood pressure can be described as the amount of force that is exerted on the walls of our blood vessels by the blood and all of the other substances that are inside of those vessels. Remember, every time the heart contracts, that forces substances into our vessels and naturally is going to increase the pressure inside of our closed transport system. The reason that we have blood pressure in the first place is because we do have a closed transport system. Naturally, the resistance inside of the cardiovascular system is going to produce what we know as blood pressure. A little comparison: if we were to take a garden hose and turn the garden hose on, as water flows out of the garden hose, there's no more resistance once it leaves the garden hose. But if we were to take a garden hose and attach it to a second garden hose, there would be a lot more resistance for that water that's going from hose number 1 into hose number 2. As long as we are maintaining our pressure gradient, blood will flow from an area of high pressure to an area of low pressure. So on the next few slides, we're going to talk much more about resistance to flow. We're going to talk a little bit about how we monitor blood pressure and how we can accurately measure blood pressure. We will talk about some of the ways our bodies will regulate blood pressure, both short-term mechanisms and long-term mechanisms, and then we're going to transition into a couple conditions that are related to blood pressure. So the first thing that you really need to know about blood pressure is that it's constantly changing inside of the cardiovascular system. We will actually see that there are two specific pressures within our systemic blood pressure, known as our systolic pressure and our diastolic pressure. And both of these together are going to make up what we understand as blood pressure. Our body's systolic blood pressure is the pressure inside of the aorta when the left ventricle is undergoing systole. So once that left ventricle is contracting and squeezing, it's forcing blood into the vessels, and that's increasing the pressure inside of the vessels. So the systolic blood pressure is the highest that pressure goes inside of our vessels naturally. Now the diastolic pressure is on the other side of this. The diastolic pressure is the pressure inside of the vessels when our ventricle, specifically the left ventricle if we're talking about the aorta, this is the pressure inside of the aorta when the ventricle is undergoing diastole, when the ventricle is relaxing and blood is actually trying to flow back into the heart but is stopped by the semilunar aortic valve. This would be the minimum amount of pressure that our large vessels feel. So you can see that as the heart is constantly pumping, contracting, and relaxing, the systolic and diastolic pressure are going to alternate. The pressures inside of the vessels are going to go up and down, alternating between our systolic and diastolic pressure. Now eventually, as blood starts to get further and further away from our arteries, the pressure inside of our vessels is going to drastically decrease. We see the pressure inside of the arterial tree is much higher than that of the venous drainage. And you can see down here at the capillaries, we're going to enter the capillaries at a pressure of about 40 millimeters of mercury, and even through the capillaries, the pressure is going to decrease. And this is what keeps blood flowing from our arterial side into our venous side. Out of all of our large vessels, the aorta is going to have the highest pressure, and the vena cava will have the absolute lowest pressure. So the low pressure in the venous side is why we have to have additional mechanisms to increase venous drainage, such as our respiratory pump and our muscular pump. As we also discussed hydrostatic pressures as blood moves through the capillaries, you can see that this pressure is going to be greater over here and promote more filtration, while as we get towards the venous side, blood pressure is going to be low enough that it will actually promote reabsorption of substances going the other direction. Now, I'll mention here that there are three major factors that will regulate our body's blood pressure, and they are cardiac output, our total blood volume, and our total vascular resistance, which can also be called total peripheral resistance and abbreviated as TPR. Now, this bullet point that I've just mentioned is a very, very big statement, and it might look a little less important on this slide, but we're actually going to see that in a couple slides, we're going to transition into the factors that are regulating blood pressure. And it is cardiac output, blood volume, and vascular resistance, which are the major factors that will control our blood pressure. So don't forget about this bullet point. This is a very, very important bullet point, and we will come back to talk about this in just a few slides. But first, before we start to go over the theory and the mechanisms of blood pressure regulation, I want to talk a little bit more about what blood pressure is and how we measure it. So I have just explained that the systolic pressure is the pressure in the vessels when the ventricles are contracting, and the diastolic pressure is the pressure inside of our vessels when the ventricles are relaxing. Now, in somebody with a healthy heart, our systolic pressure should be around 120 millimeters of mercury, and the diastolic pressure should be around 70 to 80 millimeters of mercury. So naturally, our blood pressure is supposed to be changing between 120 millimeters of mercury and 80 millimeters of mercury every time the heart contracts and relaxes. As discussed with capillary exchange, it is the different pressures inside of the capillaries that will also facilitate movement of substances in and out of the capillaries. So there are actually two calculations that we can do using both the systolic and the diastolic pressure that will give us some indication about how healthy the heart is. The first of which is known as pulse pressure. Pulse pressure is a fairly simple calculation. We make this calculation simply by taking the systolic blood pressure and subtracting the diastolic blood pressure from it. This pulse pressure is indicating how much stretch occurs between the time period of the systolic blood pressure and the diastolic blood pressure. Naturally, our vessels are constantly getting more blood pumped into them and the pressure is increasing. So they're always going to be experiencing blood in them, causing a little bit of stretch. But after that, when we have our systolic blood pressure, our vessels are going to experience an even greater stretch. So we're going to alternate between those two pressures inside of our vessels, the diastolic and the systolic. And so if we take this to calculate the pulse pressure, that would give us a pulse pressure of 40. And so this indicates that the pressure on the arteries every time the heart contracts is 40 millimeters of mercury. There's a difference of 40 millimeters of mercury. Now, as pulse pressure goes up, there's more stretch on the vessels, and that's going to be causing more damage to the blood vessels. We can think of a rubber band. The more we stretch that rubber band, the more likelihood that rubber band has of breaking. Now, pulse pressure is supposed to be below 60. As we start to get higher than that, we're going to start to sustain damage to our vessels. But there's another calculation that we can make that will also help us to assess the overall health of the heart, and that is the calculation of mean arterial pressure. Mean arterial pressure is the average blood pressure that we are experiencing throughout the day. It is important for us to note that blood pressure is always changing. And that is normal. Blood pressure is supposed to be changing at different times during different activities. Exercise is one time when blood pressure is drastically going to go up. Times of emotional stress or times of fear will also cause our blood pressure to rise. And there are also times at the end of a long day, if we've gotten home after a long day of work, or we are relaxing, that our blood pressure should go back to this 120/80. So this is our resting blood pressure, and that's where we want our resting rate to be. But again, it can be a little bit difficult to assess the health of the heart if we don't know what an average range of blood pressure would be. If we're going to be exercising, naturally our blood pressure is going to be higher for part of the day, and then it's going to go down at the other parts of the day. So mean arterial pressure gives us a way that we can assess what the average pressure that our vessels feel every day. And that calculation is shown here. To calculate mean arterial pressure, you take the diastolic pressure and you add that to the pulse pressure divided by 3. So using our typical example, 120/80 in a healthy heart, we'll go ahead and calculate this. So we take our diastolic pressure, which is 80 millimeters of mercury, and we're going to add that to our pulse pressure divided by 3. Now the pulse pressure was calculated in the previous step. by taking the systolic blood pressure and subtracting the diastolic pressure. So you end up with a formula that looks something like this. So 40 divided by 3 is roughly 13.3. We'll go ahead and round it to 13, and then we add that to the diastolic pressure, and that's going to give us a reading of 93 millimeters of mercury for a mean arterial pressure for someone whose resting rate is 120/80. Now, if your resting blood pressure goes up, that's going to change what your mean arterial pressure is. The higher your blood pressure, the higher the mean arterial pressure. And we want to make sure that our mean arterial pressure stays within its homeostatic ranges. So this slide will take you through a couple examples of calculating pulse pressure and then using that pulse pressure to give us the mean arterial pressure. And this first example is the one we've just done. To calculate the pulse pressure, you take the systolic blood pressure, subtract the diastolic blood pressure, and that gives you your pulse pressure. So this, again, is for somebody that has a blood pressure of 120/80, which is considered normal. Now, the mean arterial pressure after this will be calculated by taking that pulse pressure, dividing it by 3, and then by adding the quotient to the diastolic blood pressure. And you can see that we end up with 93 millimeters of mercury, just as we worked out on the last slide. However, blood pressure can change. And in pathological conditions, when blood pressure is too high, we'll see that we have a different pulse pressure, different diastolic pressure, and a different systolic pressure, and those are going to give us a much different mean arterial pressure calculation. So if we have a patient that has arteriosclerosis, which is a condition that indicates a loss of elasticity in our vessels, if we have arteriosclerosis, we're going to end up with this 156/90. That is a very, very high blood pressure. And we want to make sure that patients with this type of blood pressure receive the necessary medications and lifestyle changes that will be necessary to decrease this. So how do we calculate pulse pressure and mean arterial pressure when our systolic and diastolic pressures have gone up? We'll first calculate the pulse pressure by subtracting our diastolic pressure from the systolic pressure. And we can see that gives us a pulse pressure of 66 millimeters of mercury. As pulse pressure goes up, our arteries are experiencing more trauma every time the heart beats. So it's very important that we try to keep this pulse pressure as low as possible. Now, once we take this factor, we're going to divide that by 3, and that will give us 22. And then we want to add that to the diastolic pressure. But you can see in this example, the diastolic pressure is higher than it was in this last example. So we end up taking 22 and adding that to 90 for a grand total of 112 millimeters of mercury. So you can see the drastic difference between these two mean arterial pressure calculations. You can see with a healthy cardiovascular system, our mean arterial pressure reading is likely going to be under 100. But as we start to increase our blood pressure due to the loss of elasticity in our vessels, or perhaps the left ventricle pumping extra hard, that's going to cause an increase in our mean arterial pressure and lead to more damage on our blood vessels. So it's very important that we are taking the proper steps to make sure that our blood pressure is in its healthy homeostatic ranges. So it was the pulse pressure that took our systolic pressure and subtracted the diastolic pressure from it. But we should also talk about what pulse is. Our body's pulse is something that we can use medically to determine the well-being of a patient. Pulse can be described as the alternating expansion and recoiling of the walls of the arteries based on what the heart is doing during the cardiac cycle. The heart is contracting, that's going to be forcing blood into the vessels, and our arteries are going to be expanding. But in the event that our heart is relaxing, our vessel walls are going to actually be squeezing back against the blood in the vessels and propelling that blood forward through the cardiovascular tree. You have likely heard of some pulse points before and even perhaps felt your own pulse. One common pulse point is the common carotid arteries pulse point. You can feel a pulse in your neck at this location. One other common place that we will feel for a pulse is in the radial artery. Oftentimes, at the doctor's office, the physician will actually use the radial artery to calculate what your heart rate is. There are lots of pulse points that can be found across the body, and we're not going to focus too much on those. We want to focus more on what pulse is and what effects it's going to have on our body. So pulse, just like blood pressure, is going to change. Normally, during times of exercise or even changes in our posture, pulse is going to change. During times of exercise, our pulse is going to go up as our cardiac output needs to go up so that we can meet the metabolic needs of our tissues. During posture changes, like standing up too fast, that can decrease blood pressure enough to the point where we actually get dizzy. And times of emotional stress are also instances that are going to increase our pulse. So the definition of pulse, the alternating expansion and recoiling of the elastic arteries during the cardiac cycle, is what is explaining how the pressure inside of our vessels is going to push on the walls additionally when the ventricles are contracting, and how when the ventricles relaxed, pressure is going to decrease and the walls of the artery are going to squeeze back down on the blood inside of them and produce laminar flow. Now, the last major topic that I want to talk about before we start getting into discussing how blood pressure is regulated by our body, I want to make sure that you all understand how we measure and monitor blood pressure as well. And that's going to be using two special tools known as the sphygmomanometer and the stethoscope. It's likely that you've heard of these tools before or even have one at your own home. A stethoscope is a tool that's used by physicians to listen to your heartbeat and other sounds coming from the body. You can see the stethoscope here, and when you go to the doctor's office, it is almost protocol that they will use one of these stethoscopes to listen to your heart. The sphygmomanometer, on the other hand, which is a big mouthful, is also known as the blood pressure cuff, and that's probably how I'll be referring to it from here on out. These two tools together will give you the ability to assess blood pressure based on specific sounds that we hear, known as the Korotkoff sounds. This method is called the auscultatory method because auscultation means to listen. So we are listening to assess what the blood pressure is. So naturally, what we're looking for are a set of sounds that are going to indicate what our systolic and diastolic pressures are. The way that we take blood pressure using the auscultatory method is we will take the blood pressure cuff, or the sphygmomanometer, and wrap it around the patient's arm. We're going to increase the pressure inside of the blood pressure cuff, and that's why we have a little dial that's found on the blood pressure cuff. This dial is going to indicate how high the pressure is inside of the blood pressure cuff. Now, as this is wrapped around the arm and increasing in the pressure is going to get so high inside of our sphygmomanometer that it's going to close off the brachial artery. Essentially, the systolic pressure is not high enough to overcome the pressure that is inside of our blood pressure cuff. So this results in stopping the blood flow through the brachial artery altogether. We're then going to position the stethoscope on the blood pressure cuff and listen for the first sound that we hear and the last sound that we'll hear. The first Korotkoff sound will indicate what our systolic pressure is. So as we start to decrease the pressure inside of the blood pressure cuff, the pressure gauge is going to start going down, and you're going to be watching that very, very carefully. Now, as we are decreasing the pressure inside of this blood pressure cuff, it's eventually going to get lower and lower, and there will be a point where the systolic pressure will finally exceed that of what is inside of our blood pressure cuff. And you're going to hear your first sound at that time. That is the first Korotkoff sound, and whatever number the blood pressure cuff is pointing to at that time will be your systolic blood pressure. Now, as we continue to decrease the pressure inside of the blood pressure cuff, we're going to hear a few more sounds, but the last sound is the one we want to make sure that we are focusing on. The last sound indicates what the diastolic pressure is going to be. So it is the first sound and the last sound that are the Korotkoff sounds. A word of warning, you don't want to get these Korotkoff sounds mixed up with S1 and S2. Those are two different sets of sounds that indicate two different things. So this is how we can use the brachial artery to assess what our blood pressure is. It's likely you've had this very method done on yourself before.